Why is invasive lobular carcinoma recurrence risk so high? Imagine a type of breast cancer that tends to hide in plain sight, growing quietly and spreading out in ways that make it tricky to catch early. That's what makes invasive lobular carcinoma, or ILC, particularly challenging when it comes to recurrence. Unlike some other breast cancers, ILC has a unique biological makeup that influences its behavior over time. It is usually hormone receptor positive, meaning it responds to hormones like estrogen and progesterone. This makes it more likely to recur many years after initial treatment, often beyond the 5 or 10-year mark. While hormone receptor-negative cancers tend to come back sooner, ILC's hormone sensitivity means it can stay dormant for a long time before reactivating. One reason for this late recurrence is its growth pattern. ILC cells tend to grow in a single cell line and infiltrate breast tissue diffusely. This pattern makes it harder to detect early because the tumor can spread throughout the breast without forming a distinct lump. It can also be multifocal or even bilateral, meaning it can affect both breasts. During initial diagnosis, this diffuse growth can lead to underestimating the tumor's size or extent, leaving behind residual cancer cells that may cause recurrence later. Most ILC tumors are hormone receptor positive and tend to have a lower grade, indicating they grow more slowly. This slower growth rate can allow cancer cells to remain as dormant for years, only to reactivate later. This dormancy is a key factor in why late recurrences happen. Larger tumors and involvement of lymph nodes at diagnosis also increase the risk because they reflected more advanced disease, which is more likely to come back. Treatment plays a vital role in managing recurrence risk. Surgery alone, especially if not combined with radiation therapy or hormonal treatments, can leave residual cancer cells behind. Endocrine therapy, which blocks hormones that fuel ILC growth, is essential for reducing the chance of recurrence. When these treatments are omitted or not properly followed, the risk of early recurrence rises. Conversely, consistent use of hormonal therapy over many years can help keep dormant cancer cells in check. The biology of hormone receptor-positive tumors like ILC means they can stay inactive for years before reactivating. This late recurrence pattern makes long-term follow-up crucial. Patients often need extended hormonal therapy and vigilant monitoring, even beyond the usual 5-year mark. Genetic factors also influence recurrence risk. Mutations in genes like CDH1 are more common in ILC and may contribute to its distinct behavior. Additionally, individual factors such as younger age at diagnosis, higher body mass index, and low progesterone receptor levels can increase the likelihood of recurrence. In summary, the high recurrence risk in invasive lobular carcinoma stems from its hormone sensitivity, diffuse growth pattern, and tendency for late reactivation. Managing this risk requires personalized treatment plans, long-term hormonal therapy, and ongoing surveillance. Always consult with healthcare professionals to tailor strategies that best suit individual circumstances, as each person's experience with breast cancer is unique.